Let's get our afternoon session started. Let me introduce Gerald McGwin. He's a good friend of ours, a friend of the MSG. Serves as our biostatistician and statistical advisor regarding a number of the studies that we've been involved in. And I think he's, in the 2 or 3 years we've worked with him, has become familiar with the challenges that we face in terms of study design that is somewhat unique to this group of patients. So we've asked Jerry to kind of give us a segue and give us 45 minutes of his thoughts on some of the statistical considerations for these types of trials, and then after that we'll initiate the crypto discussion. Thank you. Thank you so much.
Great. Thank you, Pete. I think what Pete really wanted was a little nap time before the real material. So this is your post-lunch nap, 45 minutes of biostatistics. I can think of nothing better than to put people to sleep. I did have one announcement. A phone was found upstairs at lunch, and they're holding it at the table outside. They just asked me to make that announcement. So if anybody lost their phone, that's where it is. Last night at dinner, Pete made a request to take photographs while we're here so that we can, I guess, account for our time that was here. And so when I went for my run this morning, very much as atypical for me, I brought my phone along with me. I'm a good Catholic, so I abided by what Pete asked me to do. And so I took off for my run, thinking that I would take some nice photographs to share with the group and to document my encounter. I was very much also aware of his warnings about the wildlife. I've run all over the world, all over the country, and so I'm used to running in unusual places. I've run in Central Park in the 80s, so I know what I'm doing. And so I took this very nice photograph this morning while I was running. I'm not a very good photographer. My kids ask me if I actually open my eyes when I take photographs. So as I was running along the trail up to the top of the mountain, I heard something rustling in the woods. And so I decided I would take out my phone and document this experience just in case this was the last time I was going to be seen. So this is me sort of trying to wonder early this morning what was coming for me. Was it the elk? Was it the moose? Was it the whatever it may have been? And I hear this trampling in the woods, and it's getting louder and louder and faster and faster. And so, it very much Blair Witchish, I put my phone in my hand and started to run really fast. Really fast. Things started to get very, very blurry. And I figured at a minimum, I would be able to somehow, they'd find my body, and Pete would get these photos and at least document the last moments of my life. And again, this trampling through the woods is getting louder and louder. Of course, I don't have any bear spray. And we're coming up at a point in the road where it's going to become clear that something's going to come out of the road, and it's going to be the end of Gerald McGwin, biostatistician. And sure enough, this is what comes out of the road. So this is Jake. Jake looked at me for a few minutes. I looked at Jake for a few minutes. We exchanged some words. His were probably more pleasant than mine were to him. And off he went. So if you're up in the mountains running tomorrow morning and you hear trampling in the woods, I'd probably still advise you that it's probably not Jake. But just in case, this is Jake if you see him. So in preparing for this talk, I sent Pete an email, as I typically do when I give talks to groups like this, asking for some context for what the group may find useful. And you can see my email to Pete here, and I specifically asked him, and I asked this of many groups that I give talks to about statistics, on a scale of 1 to 10, how would you rate the knowledge of the group? And this gives me some ideas to whether I should talk about something methodologic or perhaps something more practical. And so I asked Pete, and Pete responded that for this particular group, -3.5 might be appropriate. And I became very concerned by this because I spoke to some orthopedic surgeons last week, and they gave themselves only a -2.7. The reality is Pete backtracked and said that you were about a 5, which is fine, because that puts me somewhere in between talking about flipping a coin to randomize people into a study, which is what I talked about the orthopedic surgeons about, and something much more complicated, which is spatial statistics for clinical trials. And so what I'm going to do today is shoot down the middle. This is what Pete followed up with. This is a basically a cut and paste from his email, and he outlined 4 specific topics that he thought would be relevant to this particular group, and they're very much consistent with what I've experienced working with him over the past several years. And if you boil down what Pete has outlined here, the real issue that I think is salient is sample size. It's clearly an issue for the studies that I've been working on with Pete and the group, and studies that I've been reading in this particular area. So what I really want to talk today is about sample size, and I want to transition into sample size, and it's really how do we deal with small sample sizes? How do we design studies around small sample sizes in the context of traditional clinical trial designs, but also focusing more on adaptive clinical trial designs. And hopefully it'll be useful, but at minimum, you'll get that nap, and then there was that story about Jake that you can take home. And so if we talk about sample size, these are 2 very basic sample size equations. I hate to show math, I hate to show equations, but we're going to walk through this together. These are sample size calculations for very simple sample size calculations for a comparison of proportions and a comparison of means. And if we eliminate some of the unnecessary material and we highlight the most important parts of these equations here, what's in red there is the effect size. And for a proportion or for a mean, that's largely what's driving how many subjects you need in a study. And again, that should not be surprising. All of you have either been exposed or done sample size calculations, and so you know that the effect size is very, very important. This is a conversation that I have almost on a weekly basis. This is somebody asking me about wanting to do a study, randomizing 2 groups of patients and wanting to know how many patients they need. My response in red there is almost uniform. What's the expected rate of the outcome, and what sort of an effect size? And the response is almost uniform. If they knew that, they wouldn't have to do this study. And then I sigh quite heavily. There's a variant of this. Often I get a little bit further. I get asked the same question. I give the same answer. And they give me the background risk. I do the calculation for them, and they tell me that's too many. So this really underscores the fact that the power calculations, sample size calculations, are often a trade-off. They're a give and take between what is possible versus what the statistics actually require in terms of answering that ultimate question in the study. And again, if we look very closely at those equations here, it shouldn't be that unusual that all we have to do to decrease the sample size is either increase the effect size or decrease the variability. If we can decrease the variability, we need fewer subjects in that particular study. If we can obviously increase the effect size, we can also decrease the number of subjects in the study. And again, oftentimes that's fairly reasonable to do if you're in a situation wherein you don't know what the expected effect size is, so you can have a little bit of wiggle room. The same thing with the variability. We're going to see in a little bit when I talk about adaptive designs, how we incorporate those 2 elements into an adaptive study when we don't have a lot of information up front. But in the context of a traditional clinical trial, we can still make some modifications with respect to the effect size, reasonable modifications, and the variability by taking into account some design elements, and I'll talk about that in a moment. So let's take an example here. So here are two power calculations, both for proportions, one with an effect size of a difference of 10% and a difference of 20%. You can see the dramatic impact on the sample size. We've gone from needing 384 patients per group down to 90 patients per group, simply by changing the effect size from 10% to 20%. Now, that's not often reasonable to do if you can't justify that large of an effect size. But what it demonstrates is that for differences of this magnitude, you're on a very steep part of the curve. And so while you may not be able to justify a change from 10% to 20%, a change from 10% to 15% still reduces the sample size quite dramatically. If we look, for example, this was a study that I came across recently, and if we look at this particular study, and here we're comparing 2 treatment groups, and you can see at baseline here they are equivalent in terms of the number of symptoms. If we expect a 10% difference at follow-up, we can see that if we are dealing with a proportion, comparing proportions, we also need a larger number of patients than if we were dealing with a continuous variable. So that's the other important aspect here of a traditional clinical trial design. If we can change our primary outcome from a binary variable, which requires, again, almost 400 patients, to a 10% difference in a continuous variable, again, the effect size is the same. It's a 10% difference in proportions or in means. The sample size goes down dramatically. Again, can we justify a continuous variable? Is there a continuous variable that we could use as opposed to a binary variable? Or can we power the study on a secondary outcome or a co-primary outcome in order to reduce the sample size? So again, using a continuous variable is always going to be associated for the same effect size with a smaller sample size than a continuous variable. It's just how the math works out. There's a push and pull, however, between power and sample size, and this is actually missed by a lot of people beyond their introductory biostatistics class. You've likely all seen a table like this, a type 1 error, a type 2 error, alpha and beta, in terms of making a correct decision versus an error. And in a table like this, it's very, very easy to, again, in a multiple choice exam, get it correct as to what a type 2 error, what a type 1 error is. It's actually much more instructive to see the relationship between these two by looking at these distributions. And what we see is when there's not so much of a difference between our treatment and our control group, the power is going to be much less. It's going to be more difficult than when the distributions are much different. So again, in the context of our clinical trial design, our traditional clinical trial design, do we have the opportunity to, for example, enroll patients selectively, stratify them in some way, such that the distributions of our outcome of interest do not overlap as much? Can we enroll a higher risk group of patients so that whatever our outcome is, if it's continuous, we can separate them in this way and therefore gain more power with a smaller sample size? So it's very, very important to understand about this push and pull between our alpha level, our statistical significance, and our beta. And this is often forgotten, particularly because after a trial begins, people by and large forget about power. Once the trial begins, even oftentimes, as we'll see, once the paper is published, no one's really concerned about power anymore. We're more concerned about, was the effect statistically significant? Power comes back into play if you don't find a statistically significant amount. Then you typically blame it on it was a study being underpowered, and we're going to see a little bit of that in a moment. This is another study. Here, again, comparing two treatment groups. And when they designed this particular study, they actually assumed that the baseline rate of the outcome of interest was 85%. And you can see here, in the actual results of the study, the rate of occurrence was much less than that. And so when we look, though, the differences between the two groups were still statistically significant at that alpha 0.05 level, even though they were way off on the baseline estimated risk of the outcome. But the power for this comparison was only 40% for the observed comparison. By and large ignored because the results of the study are more driven by the alpha level, the statistical significance, than the underlying beta, except if the study is not significant. There are a myriad of reviews that have gone in to calculate the observed power for null clinical trials. And the observed power in null clinical trials generally tends to be around 50%, sometimes even less than that, 10%. However, there are no studies that have gone in to compare the observed power for statistically significant clinical trial results. And if you look and you go and do some calculations, you will find that they suffer from the same power problems. Why? Because we'll go back to those emails that I get. If you knew the answer when you designed the study, you wouldn't have to do the study. Most power calculations are based on unknowns. They're based on our best estimates for what we're going to see. So again, when we talk about adaptive designs here in a minute, how can we take those unknowns and incorporate what we learn during the early phases of a study into the study design? Okay, so again, this is a recent publication in the New England Journal of Medicine, again, comparing two treatment groups here. The study was powered on the primary outcome of interest, which is the mortality risk. There was a secondary outcome of interest you can see down at the bottom. And so the power was calculated based on having this mortality, a proportion, outcome of interest. However, if we were to switch the power calculations for this study, the sample size calculations for this continuous variable, and redesign the study, it would have said that we only needed 91 participants per group in order to see that association, that difference as statistically significant. However, what would it have done to that prior primary outcome of interest? The prior primary outcome of interest would actually still be statistically significant. The p-value would be 0.05. It was 0.049 something when I calculated it. Now, the power is going to be much less. The power was about 60%, but it was still a statistically significant difference in the mortality on a much smaller sample size than was originally the case. Okay. So again, what is the best primary outcome for the study, not only in the context of whatever the drug or the treatment or the device is, but also for the design of the study? Like, again, those emails that I get, that's too many subjects. Okay, how many subjects can you get? And how can we justify the effect sizes, the outcome of interest, based on a number of potential important outcomes of interest? To an extent, we just turn on the smoke and mirror machine. So how do we apply this in the context of a traditional clinical trial? Well, as I said, we have to justify large effect sizes. And oftentimes, that's difficult to do, even when there's no prior study to suggest that we're going to see a 50% difference, a 60% difference. That's just a very difficult pill to swallow, even in the absence of any evidence. And so again, can we transition to a continuous or an ordinal outcome instead to drive that sample size down? We also have to be realistic about statistical power. As I said, few people are concerned about statistical power after the first patient is randomized. Most of our statistics around monitoring and analyzing clinical trials are focused on the p-value. How many times we look at the data, how should we distribute that p-value over the course of those analyses, et cetera. They're not focused on power. We assume that power is going to remain fixed based on what we knew at the beginning of the study, which, if you look at clinical trials, is generally not correct. It's all going to be off by a little bit. And then finally, if Pete ever invites me back to this meeting, another area wherein we can actually improve our power for a given sample size is using techniques to minimize losses to follow-up and impute missing data. If you look in many clinical trials, the ones I've done, the ones that I read on a regular basis, there's always an assumption of how much loss to follow-up there's going to be. And that loss to follow-up is lost information. It's lost statistics. We can't do analysis on things we don't have. However, there's a whole field of statistics on imputation and assuming what that missing data would have been to, again, if we have a decrease of 10% in a sample size of 1,000 patients, that's not as big of a deal as if you have 100 patients and you're down to 90. The impact on the loss of power is much greater with that smaller sample size. So imputation techniques for missing data in small clinical trials is a very, very active area of my own research, in an area wherein, again, in the context of small sample sizes, there's lots of opportunity. Okay. So I want to transition now to talk about adaptive clinical trial designs. Really what we've been talking about up till now is really how we squeeze as much juice out of a traditional fixed clinical trial design as possible. Who's heard of an adaptive clinical trial design before? Okay, so a few people in the room have. In our traditional clinical trial design, again, we enroll patients. We follow them up, and then we wait. You send your statistician away. He disappears for 2 years, for 3 years, and you invite him back when all the data is done, and we analyze the data. And you make a decision at that point in time as to whether the treatment was effective or not. There are what are known as group sequential designs, which have been around formally since the 1970s or so, wherein we modify this design to, at some point during the trial, we stop, we do an analysis, and we make a decision. We make a decision as to whether the trial should continue or the trial should stop because one treatment is definitely superior than the other or definitely inferior than the other. That then may go on to another analysis wherein you make the same decision. And then finally, at the end of the study, you then would analyze the data. And we would have to do some statistical techniques to account for the fact that we've analyzed the data twice previously before we got here. Again, the methods for that have been around for a long time and are fairly easy to implement. The adaptive clinical trial designs really grew out of these group sequential designs, where you pause at some point during the trial and do something. Again, in the context of these group sequential designs, the thing that you do is decide to stop the trial or continue the trial. In adaptive designs, we actually do that analysis and then we talk about making modifications to the trial. We actually change or introduce the possibility to change how the study is being conducted while the study is being conducted. These are some examples of what some of those changes might be, and I'm going to talk about them in a moment. But one of the changes that you might make is that you actually reassess the sample size. It is, to an extent, illogical to design a study based on very sketchy information, and then to begin the study with now information that you didn't have before accruing, and not actually pause, take a moment, use that data, and reassess how accurate you were in your guesses about those sample sizes. And so when we take these pauses in these designs, we can actually reassess the sample size and either augment it or decrease it, depending on what the case may be. There are other types of approaches here wherein we actually transition the randomization. Instead of being from 1 to 1, we might actually change it from 2 to 1 if it's clear that one of the treatment groups is actually doing better than the others, and we want to randomize more patients into that particular treatment group. And so we, instead of having, again, our 1-to-1 randomization, we change the randomization from 1 to 1 to 2 to 1. And again, that can potentially benefit our sample size if that obvious treatment group that we're apportioning people to is actually better. Another example wherein we can make an adaptation is we can actually change the inclusion criteria and actually include people in the study who we might have previously excluded. And we'll see an example of that in a moment. One of the very, very, very important things about these adaptations is that they're not ad hoc. We don't just stop the trial 6 months in and get together and make some changes. All of the changes have to be planned at the beginning. It is a very crucial aspect of these adaptive designs. It's crucial because you don't want to seem as if you're introducing bias into the study, but also they impact the statistical plan. How many times we look at the data and the decision that we make can wreak havoc on the statistics that get done at the end, and we'll talk a little bit about that in a moment. The goal here for these adaptive designs right from the beginning, when they've been introduced, again, back in the 1970s and 1980s, has always been to make them more efficient. How can we reduce the time it takes to do the study, and how do we make the trial run more efficiently? The issue here is that despite the long history of these study designs, they actually haven't been implemented that widely. There was a review conducted recently on adaptive clinical trial designs to enumerate what types of adaptations have been made and in what fields have these been made. And you can see here, as a result of this flow diagram, the number of truly adaptive designs in the published literature is actually quite small. But if you look, they've been increasing. This is a bar chart showing the the proliferation of these designs, again, in the past several decades. And the types of designs that are being used have also been changing. The fields in which these adaptive designs, you can see them listed here, not surprisingly, oncology, and then there's a very large other category there. I did several fruitless searches, to find some truly adaptive designs in fungal diseases, and they either don't exist or my search strategy isn't working correctly, but they are not as common as they are particularly in cancer and cardiovascular disease. This is really where the rubber meets the road. So from this particular review, they actually calculated both the duration and the sample size in studies that had adaptive designs and in studies that had traditional designs. And you can see there the fairly meaningful difference in the length of the study for an adaptive design, both in phase 2 and in phase 3 trials compared to a traditional design. Now you'll note that the sample size, actually the median sample size, does not decrease, but it didn't decrease in the face of a shortened duration. So most of these studies would accelerate the rate at which they're enrolling patients based on these adaptations. So these clinical trial designs come in a variety of different types. These are probably the most common, and among these, I'm actually not going to cover most of them. Sample size re-estimation design, drop the loser design, biomarker adaptive design. These are some of the more common ones that appear in the literature. The most common ones that are used are seamless phase 2, phase 3 designs. Okay, these have been around for a while. They're very, very common, and I'm actually not going to talk about them because they're not as interesting. Of the remainder, though, we can see that following those are group sequential designs, and after those are biomarker adaptive designs, adaptive dose finding designs, and then we go down in frequency from there. As we've mentioned, these classical group sequential designs have an interim analysis on which they make a decision about whether to continue the study or stop the study. These adaptive designs are making changes to the study design. And as I said, this really began in the 1970s with this particular paper here, talking about how you adjust the p-value for those interim looks at the data. So if we look at the sample size re-estimation design, again, this gets to this point of if I knew the effect size, I wouldn't be doing the study. Basically, what it allows us to do is after a certain period of time, we can actually stop the trial and actually use the accumulated information on either the nuisance parameters, the variability, or the baseline risk or rate of the outcome, or in more extreme cases, we can actually calculate the effect size in the actual study, feed that information back into our sample size calculations, and then make a determination as to whether we need to adjust that sample size. So again, in this particular example, we start off with a fixed number of patients, 683 patients in this particular study, and a primary outcome of expected 10% and 15%, the alpha and the beta you can see there. So if we decide to stop the analysis at the first 100 patients and we happen to observe that the rate of occurrence is actually 20%, so the effect size is actually bigger than we expected, if we go ahead and redo the sample size calculation, we can see that we can drop that original 683 people per group down to almost only 200 per group, which is obviously going to reduce both the length of the study and then obviously the burden of enrolling patients. In a context of 1,000 or 683 per group, that's a fairly dramatic decrease, but even in a study where you can only enroll 100 patients, that's still a meaningful pullback in terms of the amount of time and the amount of resources that you can dedicate. And you'll note that the alpha and the beta remain the same for that reduced sample size. As I said, we can do this two different ways, blinded or unblinded, and that refers to whether one of the things we're estimating is the effect size or just the nuisance parameters. If we actually just estimate the nuisance parameters, which is to say the baseline rate of occurrence of the outcome, or the variance, we actually don't have to modify our p-values. So as a statistician, I like that. If you want to do an unblinded and actually calculate the effect size, then we have to do some statistical gymnastics at the end of the study to account for that. The drop the loser design, so this pretty much describes my dating career in high school. I'll let that sink in for a moment. Okay, we'll move on. So the drop the loser design, I think the more politically correct version of this is the pick the winner design. This picture doesn't help in either case. And so in the drop the loser design, this is obviously done in situations where you have more than 2 treatments that you're comparing. And over the course of the follow-up, again, at these interim analyses, what you do is you actually drop treatment arms. You drop the underperforming treatment arm. And in so doing, you obviously reduce the sample size, or you can maintain the sample size or reapportion that sample size to the other treatment groups, again, thereby reducing the sample size because you've bolstered how many that you were going to have in those groups compared to what you planned. This is a table from a statistical paper wherein we were looking at the effect of this drop the loser design and the reduction in the sample size based on a couple of different parameters. One is the number of times you look at the data, and then the number of treatment groups. And you can see that no matter what scenario you can look at in these simulations, we were always able to simulate a reduction in the sample size, regardless of how many times we looked or how many treatment groups there were. And so this drop the loser design, if it can be implemented, can actually result in some fairly dramatic reductions in the sample size requirements for a study, which is particularly important when sample size is difficult to come by right from the beginning. The next one I want to talk about is the adaptive randomization design. I mentioned this previously. And in these particular study designs, at those points of decision, at the interim analyses, we reapportion the randomization ratios. If we started off with 1-to-1, we may make a decision to change it from 1-to-1 to 1-to-2, 1-to-3, based on some, again, a priori calculations. And we can actually see, for example, in this hypothetical study here, if we start off with a study that has 100 patients in each group, and we take 4 looks at the data, the percent with the positive response, you can see that after the first interim analysis, I would drop the treatment D, and then I continue on with 3 different groups. And you can see the effect size there as the study goes on. The important thing is to see what actually happens to the sample size. As I lose this group, I actually pick up 75 patients that I can now reapportion to these other 3 treatment groups. And then after this third look at the data, I pick up 50 patients, 75 patients rather, that I can reapportion to these treatment groups. So now the power for this comparison here is much greater than it was planned at the beginning. So again, this is a very nice adaptation, A, if you have obviously more than 2 treatment groups, but B, if you're potentially interested in dose. And you want to find some way to potentially bolster your sample size while also looking at the issue of dosages and escalating them in a way that you can maintain your power and actually increase your power throughout the course of the study. The last one I want to talk about is a biomarker adaptive design. Of the designs that we've talked about here, this is probably the newest one. And in this particular study design, there are a number of different variations of it, at least 8 that I'm aware of. It's all based on what we know about a biomarker for an outcome that you're actually interested in. In this particular design that I've illustrated here we're not aware of the biomarker, but we actually use the data after an interim look at the data to identify a biomarker that's associated with a heightened response, a greater effect size. And so after that interim analysis, we actually then only enroll patients that are biomarker positive for that particular test. And now, instead of expecting an effect size of, let's say, 10%, those that have the biomarker have an effect size of 20%. And now, when the trial goes forward, we're going to require a much smaller sample size because we have a much larger effect size. Now, these biomarker adaptive designs come in, like I said, a variety of different formats depending on what we know about that biomarker and how we incorporate them, how and when we incorporate them into the trial. But in all of those designs, we're taking that information and we're modifying the design over the course of the study to focus on reducing the sample size while maintaining our statistical power. Okay, so in summary, so these adaptive designs, they allow for more dynamic clinical trials. Again, many of us are taught about very static clinical trials. You enroll patients, you randomize them, you wait, and then we analyze it. These clinical trial designs, which I hope I've done in a very short period of time, they become much more dynamic. And we can now make changes to them in this case here with a focus on maintaining power but reducing sample size by using information that we learn from the study itself. We can use these designs to offset uncertainties, and sometimes these uncertainties are great. It doesn't take much looking through the literature to see studies that were way, way, way off in terms of what they observed and what they predicted when designing the study. An adaptive design lets you account for that rather than sitting on your hands and just saying, let's let the study play out the way that it's going to play out. It can increase the efficiency. We've shown this with our research, with simulations, and in real studies. You can actually improve the efficiency of the studies. And they are gaining wider acceptance. I haven't mentioned any regulatory agencies in this discussion here, but I can tell you that they are gaining wider acceptance when designed properly. There are downsides. The statistical analyses associated with these adaptive designs are very intensive. They're not insurmountable. But they are very intensive. It involves the work of a statistician at the beginning, in the middle, and at the end of the study, as opposed to in a traditional design, you really only need one at the end. But the statistics have been worked out for all of these study designs and all of these adaptations. Much of it theoretical, but still, the work exists to actually apply it in real world. One of the difficulties of actually implementing these study designs is that there are uncertainties. If you begin an adaptive study not knowing what the final sample size is going to be, planning a budget, planning a timeline, planning for human resources can be quite difficult. However, again, if we build into those interim looks at the data some assessment of that, we're going to have a fairly good idea as to what those resources are going to be. And then finally, the reality is that if we look at the research on adaptive designs, it's been much more theoretical. It's probably a ratio of 10-for-1, the number of theoretical statistical papers on adaptive designs, both design and analysis, and their actual application. It's not clear to me why they're not more widely adapted. They are complicated. I'm not quite sure that they're as well understood as they are if you do this type of work. But nonetheless, they represent opportunities, and they are being used, both in infectious disease, chronic disease, device manufacturers, drugs, et cetera. So they are becoming more popular, and again, some of the regulatory hurdles are, in fact, surmountable. So I think we're going to continue to see them being used in the future. So that's all I have to say. I have 4 minutes left before Pete gives me the hook. I'll be happy to answer any questions.
It was excellent talk, and I think that was precisely what we needed to hear. Jury's open for questions, and we do have some time. So, John, I'm sorry.
I can hear you.
So, with power design, if you're underpowered, the power determines your probability of seeing positive result, and if you're underpowered, you reduce the probability of seeing that positive result. But likewise, if you do see a positive result, it's exaggerated.
It can be exaggerated. And my point is that we often ignore that. We often ignore the fact that we've seen a statistically significant result, therefore it's real. And again, the smaller that p-value is, the more likely that is to be true. And at that point, it's just like the discussions this morning about sensitivity and specificity. It's a push or pull. At that point, what are you more interested in? Are you more interested in being right or being wrong? And in the context of a fixed sample size, where there is no opportunity to get it bigger than 50 or bigger than 100, you're never going to make the power work out. The question becomes is, among those statistically significant results, how do you interpret them best? And you interpret them not just looking at the p-value, you interpret them based on the power. And the power, like I said, is rarely going to be what you want it to be.
John Rex?
Jerry, thank you. It's interesting to listen to that meditation on this challenge. What do you do? I was struck by your example of saying you get partway in and you now conclude that you can shrink the study. That's a piece of information that everybody in the study is now aware of. And even so, you're doing an adaptive program, and the committee comes back and says we can go from 600 per arm to 200 per arm. That means something. And even if you've not shown me which arm was doing better, is there a concern about that knowledge influencing behavior?
We're humans. We're always concerned about decisions and how it impacts our behavior. So this is where we would make a decision about it being a blinded versus an unblinded. If it were a blinded analysis, the only thing we would be re-estimating were the nuisance parameters, the variability or the baseline risk of, let's say, mortality. And so in that instance there, look, people don't understand the difference between standard error and standard deviation, let alone that the interim analysis showed that the variability was smaller. That's unlikely to change their behavior because it's difficult for people to interpret that in the context of the effect size, and we haven't re-estimated the effect size. If in the context of an unblinded analysis, wherein I told you the effect size is different or bigger, that would really be no different than in a group sequential design, where it's an interim analysis, we did the analysis and we decided to stop or continue. Again, keep in mind, those boundaries for stopping early on are very, very wide in the study. And so for you to read something into it that we're making a change is no different than the changes that we would make in, again, historical group sequential design, where we decide to continue on even though we looked at the data and we saw a positive response. It just didn't exceed those O'Brien and Fleming or Pocock boundaries.
Well, so may I go one more step, Pete? Are we okay for time? Yeah. So if I go one more step there, when you do the classical interims, and as you said, they're set with enormous, it has to be a stonkingly big positive or negative effect for the committee to come back and say stop, right? That's the design. It's wildly futile or it's wildly superior. Here, it feels like you might be working with what could just be a random walk. There is, we're talking about not hundreds of thousands, we're talking about hundreds, and it could be, or even maybe even just the high double digits. Could it be that you just happen to have, partway into the trial, reached a point where there's a little more divergence between the two arms, but when you do more of it, it's actually going to regress a little bit more towards the mean, and in fact, it's a mistake at that point to say, the effect size is actually bigger, and I can do a smaller trial, because you're taking a chance that you're trusting that those first patients are representative of the rest of the data set.
That's right. So I'll make two comments. One is that's the same risk you run in a traditional group sequential design, and you offset it by the width of the boundaries. Right. So keep in mind, all these adaptations are built on that same group sequential design. And so if I inferred that we're making this a random walk and that decision isn't based on, really big effects, then that's my fault. Because again, these decisions, these adaptations that we're making are on the same, again, calculation of let's not make this decision until we've exceeded some limit here. The adaptations all come on the back of those traditional interim analyses where we have to specify the effect is this big before we do this. That's the first thing. The second thing is we may decrease the sample size as at our first interim analysis, but to counter your point, we may actually increase it after the second one. That's the dynamic nature of these designs.
Fascinating. All right, is there time for one more, or do we need to move on? Does somebody else have a question? This is good talk, and there's lots to be unpicked here for those interested in trial design. I'll stop.
Okay. Thank you.
Thank you.
That was terrific. Thank you a lot.